CPAP and non-invasive ventilation are respiratory support modalities that can be used acutely and long-term to support a patient's breathing. CPAP provides continuous airflow to reach a set pressure. This can be delivered by multiple ways to the patient, including through a mask applied to the face. At home, CPAP is usually used for severe obstructive sleep apnea. Non-invasive ventilation is simply positive pressure ventilation delivered via a mask applied to the child's face. The machine used is simplified for use at home, but the settings are comparable to positive pressure ventilation in other settings. Patients may be using these modalities at home, but the purpose of this video is to provide guidance to using therapy in a hospital ward setting. NIV and CPAP increase aerosolization of infectious agents from the airway, and so use of personal protective equipment should follow institutional recommendations. Treatment settings will be prescribed by medical staff, including the pressures, the inspiratory positive airway pressure known as IPAP, and the expiratory pressure or EPAP known as PEEP in ICU settings, and the breaths delivered per minute. Settings will be adjusted as needed according to the patient's clinical situation. As machines are designed for home use, accessing the menu to allow a clinician to change settings requires unlocking the machine. This is achieved by holding down two buttons for 5 seconds until the settings menu appears on the screen. How to do this is specific for each model of machine, with one example shown here. Instructions specific to each machine are included with the equipment bag. Any change to settings should be prescribed by the responsible consultant. Pictures of how to set up each system are provided in prompt documents named for each machine. Search for CPAP in the prompt menu and find the appropriate machine. Each document contains pictures of how to set up the circuit, how to fill the humidifier chamber, and how to turn the machine on, specific to each machine. For each patient, you need a machine, a bacterial viral respiratory filter, tubing, an oxygen port, and a mask and headgear. Insert the humidifier chamber into the machine. Plug the machine into mains power. Connect all parts of the circuit in order. The filter to the outlet of the machine, then the tubing, then an oxygen port if required, and finally the mask and headgear. Fill the humidifier chamber with water up to the maximum line on the side. Disconnect the mask from the tubing. Turn the machine on and check it is blowing air. Cover the end of the tubing and watch the screen to see that it is reaching the pressures you have set. If you leave the tubing open and the machine running, it will sound a high leak alarm. Fit the mask on the child's face without the tubing connected. You may need a second person to help with this, especially for very young children. Ensure the headgear is positioned correctly around the head. The bottom strap should sit snugly at the nape of the neck. The straps need to hold the mask in position but not be too tight. A good test is where the 2 fingers slip easily under the straps. There are different mask choices available and you will be guided by the treating team. Here's an example of a nasal mask being fitted to a younger child. Once the mask is fitted, connect the tubing to the mask. The mask should be on without the tubing connected for as little time as possible so that the patient is not breathing into the mask without support. Less than a minute is ideal. Check for leaks around the mask, particularly around the eyes. Make minor adjustments to mask fit as needed by adjusting the straps on both sides at the same time so that the mask stays central on the face. Some leak doesn't affect the efficacy of treatment, but it is preferable that if leak's unavoidable, it is coming from the bottom of the mask. You will feel air leak from the exhalation port or holes in the mask. This is normal and required to clear CO2. If oxygen is not required, the oxygen port should be capped. Assess clinical status, including oxygen saturation. Regular blood gases will be needed to assess PCO2. Medical prescription is needed if changes to treatment settings are required. The choice of mask may need to be revised if leak is excessive. Non-invasive ventilation can cause air to be swallowed, resulting in gastric distension, and so use of a nasogastric tube is ideal and should be regularly vented. A nasogastric tube sits under the edge of the mask without causing significant leak. Protect the skin from pressure sores with cushioned tapes or pads like Duoderm. This is best used before the skin breaks down, so assess regularly and use if skin is red, or use preemptively in children on more than just nighttime ventilation. Most non-invasive ventilators have alarms. Some of these are inbuilt to the device and some can be set by the prescriber. If there is an active alarm, an audible tone and flashing light on top of the machine will appear. What caused the alarm to trigger will appear on the screen. The alarm can be temporarily muted while you address the issue, otherwise the alarm will disappear as soon as the problem is fixed. The most common alarms are high leak, which means a part of the circuit has become disconnected, or non-vented mask is detected when the exhalation ports are blocked or an incorrect mask is being used. If stopping or pausing treatment, turn off the machine and immediately remove the mask. The mask should be removed by releasing the minimum number of straps or clips possible to make it easier to put the headgear back on when treatment is restarted. Instructions for daily cleaning and care of equipment are on prompt. Equipment should be washed daily in soapy water and air dried. All equipment can be sterilised and reused if treatment is no longer required for this patient, so please keep all the equipment together for return to the Children's Sleep Centre. Thanks for watching, and please seek advice and support if you're not sure or are having difficulty.